Carl, thank you so much for that introduction, and good afternoon, everybody, to the co-chairs and the members of this subcommittee. Elise and I are excited to be here representing CSG's Health Innovation Team. Our innovation teams at CSG are working to identify new opportunities to serve CSG members and engage new partners to analyze innovations in public policy happening all around the country. If there is any policy area where innovation is happening on a daily basis, it is, of course, health policy, something we've all seen firsthand over the last year. As you all begin work with the new National Task Force and try to decide where you want to concentrate your efforts over the next 2 years, we want to take you on a journey to the recent past and tell you about some of the things that your predecessors on the previous Healthy States Task Force discussed. We'll also bring you forward here to 2021 to tell you about some projects that CSG is working on this year that draw on some of the threads from that first task force. And we will take you into the halls of state capitals to hear about the key health policy issues that state legislatures and governors have been talking about so far this year. Next slide, please. But first, I want to begin with Healthy States Mark I. When that first task force began its work back in 2019, they certainly could not have foreseen the unique challenges that lay ahead for healthcare. But as the pandemic took hold last year and we moved our meetings to Zoom, that group showed the same resiliency, flexibility, and commitment to innovation that we've seen across the country these last 15 months. Next slide. One issue that rose to the top for all of that task force's 4 subcommittees, given its increased importance during the pandemic, was telehealth and telemedicine. Next slide. That was an issue very much on the radar very early on for the What's Next Leveraging Innovation subcommittee that I staffed. And when we started out talking, and what we started out talking about in 2019 was how telehealth was in some ways being held back by a patchwork of different kinds of laws around the country. And while it was growing in popularity, it hadn't yet reached a critical mass amongst either patients or providers, I think it's safe to say. Flash forward to 2020 when stay-at-home orders and quarantines and social distancing meant that regular doctor visits had to move to a different format in the interest of public health. State governments and the federal government, meanwhile, stepped up to remove many of the barriers that had long held telehealth back. The federal government, through the Centers for Medicare and Medicaid Services and other agencies, moved to increase the types of providers who could provide telehealth services, allowed them to use different kinds of telehealth modalities, including telephone, updated reimbursement rates, and expanded the kinds of originating sites eligible for telehealth visits. State governments expanded Medicaid coverage, required private insurance to cover telehealth services, and allowed out-of-state providers to use telehealth to treat their residents. And telehealth, as we all know, became an important part of keeping Americans healthy and engaged with providers throughout the pandemic. Going back to last December, we saw CMS confirm that the unprecedented expansion of telehealth would be permanent and declare that a new era in healthcare delivery is upon us. States, meanwhile, in recent months have moved to update and improve telemedicine laws and make pandemic era changes permanent. Now, it should be said that some of that change remains a work in progress. While telephone visits with your doctor were a lifeline during the pandemic, no one necessarily envisions that as the most innovative future for telehealth. Nevertheless, telehealth remains on a path to continuing utility, expansion, and flexibility going forward. Next slide. The Leveraging Innovation Subcommittee also highlighted how emerging technologies and healthcare innovations can help remove barriers to access to healthcare. And telehealth is a perfect example of how public policy decisions can smooth the path for those barrier removing innovations. Next slide. Healthcare data was another key focus for the subcommittee. There are increasingly voluminous amounts of data being produced every day, and an increasing number of issues about data that need to be addressed from a public policy standpoint. The quality of the data, the interoperability of different kinds of data, data privacy, data sharing across platforms. Artificial intelligence is one of those data related innovations the subcommittee was focused on very early on. AI in healthcare involves the creation of computer algorithms to analyze, classify, and base predictions on healthcare data at higher speeds than our human brains can. As the pandemic began, AI was expected to play a big role in everything from predicting outbreaks to the search for treatments and vaccines. And there were many examples of where data and AI were deployed. But I think what we heard from some folks is that the still nascent way AI is being addressed from a policy level, and the way doctors and researchers are just beginning to understand how to use these tools in their work, meant that AI may be much more relevant during a future pandemic than it was for this one. We heard from data experts from that the pace with which the pandemic overwhelmed healthcare systems, the lack of quality data available, and the lack of testing time may have limited the applications for AI during this pandemic. It's hard to find time to write new algorithms when you have an ER full of patients. Next slide. Data is also key to making electronic health records function, of course. When I first started at CSG 15 years ago, I was writing about EHRs and their potential to optimize care, reduce medical errors, improve coordination between providers, and empower patients to participate in their own care. One of the key policy challenges facing EHRs has always been and continues to be interoperability. Whether different proprietary systems can talk to each other, share data, and know that the person who went to this hospital on this date is the same person who went to another hospital on a different date. And early last year, we saw the federal government issue a couple of long anticipated rules with regards to interoperability. Next slide. As I mentioned, the subcommittee emphasized what states could do to help enable the innovations that can reduce barriers to access, whether it's by investing in broadband coverage expansions to allow more telehealth, along with remote learning and working from home on Zoom meetings, as many of us have now done for many months, or building out the infrastructure for 5G, which can enable things like the fast transfer of large data imaging files and the real time remote monitoring of patients. We even learned that doctors in China in 2019 used a 5G connection to perform remote brain surgery on a Parkinson's patient who was thousands of miles away. Next slide. The subcommittee recommended that states consider encouraging discussions around the adequacy and relevancy of privacy provisions under the Health Insurance Portability and Accountability Act, or HIPAA, and enact data privacy laws that provide enhanced protections. When HIPAA was passed in 1996, there was no way Congress could have foreseen the sheer volume of patient data being generated today, and that is regularly shared outside the clinical setting from smartphone apps and wearable tech like watches and other gadgets. Next slide. The precarious condition of rural hospitals and healthcare facilities was already at the top of the policy agenda as the subcommittee was beginning its work in 2019, and the pandemic has certainly exacerbated many of the challenges there. But interestingly, it wasn't necessarily an influx of COVID patients that challenged some of those facilities. It was folks with other ailments staying away from hospital emergency rooms and the halting of most elective surgeries in many states. Our friends at CSG South, by the way, recently came out with a new report on rural hospitals in the South during the pandemic that's well worth a read for those interested. Next slide. Obviously, social justice issues were a big part of the story of 2020 as well. And one focus for us was on reducing disparities in the healthcare system. The subcommittee recommended that states consider working to identify and understand inequities, social determinants of health, and disparities in the healthcare system that may limit access. One of the many state examples we have in the task force final report came from Ohio, where Governor Mike DeWine created a minority health strike force to fight racial disparities in public health that emerged during the pandemic. That panel issued 34 recommendations aimed at dismantling racism to advance health equity, reducing discrimination and increasing diversity in the health workforce, increasing access to health care, decreasing the digital divide, and strengthening data collection to better track disparities, amongst other things. Next slide. And then finally, the Leveraging Innovation Subcommittee looked at another important use for healthcare data, deploying it to complete a long sought transition from fee for service based healthcare to value based care, which experts believe has the potential to provide greater transparency and accountability, lower healthcare costs, and better health outcomes for patients. At least 48 states have implemented value based care or payment programs to one degree or another. Next slide. The State Health Systems Return on Investment Subcommittee, which included this group of folks from around the country, focused on population health and care delivery. Next slide. Addressing the social determinants of health was a key interest for this group as well. They recommended that states focus on clinical community linkages that improve health outcomes and reduce costs, and public-private partnerships to address unmet needs. Next slide. And health equity was part of their work as well. They noted that one of the important ways to address health equity is by removing barriers to treatment for underserved populations. So, again, barriers to access. And you all will get to hear much more about healthcare inequities from our friends at the Commonwealth Fund and the Kaiser Family Foundation in the next session this afternoon. Next slide. Preventing chronic disease. The United States has $3.5 trillion in annual healthcare costs, and chronic diseases, including obesity and diabetes, are a large part of that number. This subcommittee recommended, as the World Health Organization has, the implementation of evidence-based approaches to managing chronic disease. Next slide. This subcommittee said the states can consider managing Medicaid, including Medicaid expansion to improve individual outcomes and population health. Next slide. One aspect of Medicaid expansion are those 1115 demonstration waivers that allow states to test new approaches. Recently, we've seen a number of states make these waiver requests to extend Medicaid coverage to at least 1 year postpartum as this nation faces a maternal health crisis. The subcommittee said states can seek to leverage those waivers to improve health outcomes while increasing value to patients and the state. And you will hear more about improving health outcomes later this afternoon as well. Next slide. And finally, the subcommittee recommended that states consider integrating community healthcare workers into primary care. These are folks who are either paid or volunteer and who come from the communities they serve and thus have the trust of the people who live in those communities. They can provide culturally appropriate care and help address many of the health equity issues in traditionally underserved places. Next slide. And now I'm going to ask my colleague Elise Gurney to tell you about the work of the previous task force's other two subcommittees.
Thank you so much, Sean. First, I'll be discussing the Capacity, Preparedness, and Resiliency, or CPR subcommittee. It was staffed by our colleague Vanessa Grossel and include the individuals shown on your screen. Next slide, please. The group spoke to the value of investing in prevention and preparedness ahead of a natural disaster or a public health crisis like the pandemic. The subcommittee suggested states consider prioritizing investment in their public health infrastructure, which, as we saw, did remarkable work over the last year despite being stretched so thin. Next slide. The CPR subcommittee also focused on best practices for building resiliency to allow for quick recovery from a disaster or crisis. The pandemic helped us identify examples of resilient systems and also systems that were less adept at overcoming challenges. Next slide. Reflecting and anticipating some of what we've seen in recent months, the subcommittee also suggested that states consider educating their populations about vaccines and working with public health partners in supporting broad policies and robust measures to administer vaccines, therapeutics, and diagnostics. Next slide. And then the final subcommittee within the first Healthy States Task Force was the Interventions to Save Lives subcommittee, which included the individuals you see on your screen. Next slide. A primary focus of this group was redefining disease and management systems. Here again, they considered the importance of addressing chronic diseases as well as preventing bloodborne diseases, including those associated with substance use. Next slide. The subcommittee also highlighted the need for behavioral health access for all, including children. They noted that as we resume in-person education on a full-time basis, schools can be an important resource and hub for behavioral health services. Next slide. And finally, the Interventions to Save Lives subcommittee highlighted the issue of adverse childhood experiences, which are physical and emotional abuse, neglect, and household dysfunction that can have a profound impact on lifelong health and opportunity. The group suggested that states consider measures to prevent adverse childhood experiences by seeking to understand and mitigate their social determinants and by promoting cultures of detection and growth in cities, workplaces, and schools to identify and address their lasting effects. And I'm now going to turn it back to Sean for a look at how some of the issues from the prior task force are being expressed in other current CSG projects.
Thanks, Elise. One of the CSG projects that I'm really excited to be involved in this year is a project that we have with our friends at the Commonwealth Fund. You'll get to hear from Rachel in a bit. But what this is an initiative to examine some of the most pressing issues in mental health. We're highlighting 4 focus areas: social isolation, maternal mental health, social determinants of mental health, and mental health insurance parity. The end goal is to create a resource guide for state policymakers with publications delving into those 4 focus areas and highlighting the most effective policy and programmatic solutions and interventions across a variety of settings. We've stood up a 21-member advisory group made up of state legislators from 8 states, executive branch health officials from 8 other states, including a few state Medicaid directors, and subject matter experts in each of our focus areas. That group is advising us as we put that resource guide together. We convene monthly on Zoom to hear from the experts and ask questions. We're about halfway through the process right now, and we expect that resource guide to be out in September. Next slide. Some of the things that we've learned so far: social isolation and loneliness have been prevalent in recent years, and the pandemic exacerbated an already serious problem. The focus of many solutions and interventions has been on preventing isolation among older folks, and certainly there was a fair amount of that during the pandemic as nursing homes were forced to close to visitors. But the younger generations are struggling as well. Researchers found it is actually Gen Z, those college age kids and slightly older, that are the loneliest generation. Post pandemic, there's an opportunity to focus policy on greater access to mental health care, certainly, but also greater inclusion, social integration, and engagement for all. State strategies in this area can focus on incorporating social emotional learning curricula in schools, school-based health centers providing access to telepsychiatry services, teacher education, and educating more mental health providers. Next slide. On maternal mental health, we've learned that mental health disorders among pregnant and postpartum women are on the rise. Women frequently receive inconsistent messaging about the continuation of psychiatric medications during pregnancy and breastfeeding. Women with postpartum psychiatric disorders have a higher mortality rate. Untreated mental illness can have profound consequences not only for mothers and their children, but for society as a whole. There are significant barriers to addressing maternal mental health, including provider shortages, social determinants of health, and the way postpartum care is structured in this country. But state strategies can focus on increasing screening, adjusting insurance and Medicaid coverage, creating hospital programs that support mothers and babies, more postpartum home visits, and yes, more telehealth resources. Social determinants and insurance parity are still ahead for our advisory group, and we've got our next meeting coming up on Friday, so that work continues. Next slide. Maternal mortality and the nation's post-pandemic mental health epidemic are both going to be on the agenda for our CSG Medicaid Leadership Academy coming up in late September in my old stomping ground, Washington, D.C. We have a good group of policymakers registered to join us for that one, and we'll be talking about pandemic lessons for long-term care as well. I believe we're nearly at capacity for that particular policy academy, but if you are interested in our CSG Medicaid programming, we'll also be doing our very popular Medicaid 101 Academy during the CSG National Conference this December in Santa Fe, New Mexico. And we would love to have you join us for that. I'm looking forward to eating at all my favorite restaurants in and around the plaza there in Santa Fe. And I hope my friend Elise, who spent a little time in New Mexico, will support me in this. If anyone asks you red or green in December, but really any time of year, the correct answer is always Christmas. And now Elise is going to take us through what we're seeing in state capitals this year on the health policy front.
Thank you, Sean. I am a proud New Mexican. My position, though, is that any chili is good chili. As Sean mentioned, I'll be discussing trends that we're seeing in healthcare policy this year, starting with state legislatures. One issue state legislatures have been exploring are ways to expand healthcare coverage. There are a few provisions in the American Rescue Plan that impacted marketplace insurance plans and Medicaid expansion. So some states have been considering how those may factor into their plans moving forward. At least 5 states this year have also considered legislation to study or implement a state-based public option, which would use government purchasing power to offer new coverage plans to consumers. Nevada, for example, passed its proposal, and Washington State passed changes to its public option program, which is being implemented this year. The high cost of prescription drugs has been another concern for legislatures this year. At least 10 states have considered or are considering bills to create affordability boards, which would collect and review prescription drug price information. 5 states considered international reference pricing legislation this year as well. This seeks to limit the prices that state entities, health plans regulated by the state, and employee retirement plans pay for the costliest drugs. So it's limiting those to prices paid by the 4 largest provinces in Canada. And these bills draw on model legislation developed by the National Academy for State Health Policy, who you'll be hearing from later this afternoon. In addition, 5 states this year have considered bills to impose fines on brand manufacturers for unsupported or excessive price increases. And at least 18 states considered bills to either expand or establish drug importation programs this year. States have also turned to data-driven cost transparency and accountability efforts to address concerns about rising healthcare costs. Cost growth benchmarking programs, like one enacted in Nevada, bring stakeholders together to set cost growth targets, collect data from payers to measure progress, and identify where additional action may be required. As we've noted already, states have been working to pass legislation to make many pandemic-era efforts to be permanent, including expanded access to telehealth. They are including audio only in telehealth definitions, expanding the types of services that can be covered via telehealth, such as behavioral health services, and requiring payment parity for telehealth services. States are also working on strategies to address the nation's behavioral health needs, including around mental health and substance use disorders. Several states have looked to invest tax dollars from legalized marijuana sales to expand access to crisis, treatment, and recovery services. And then finally, as Sean mentioned earlier, expanded Medicaid coverage for postpartum women has risen to the top of the policy agenda for some states. The American Rescue Plan gives states the option to extend Medicaid CHIP eligibility for pregnant individuals enrolled in the program for 12 months postpartum. States have also used, and CMS has approved, Section 1115 demonstration waivers to extend such coverage. Next slide. The last topic I'll touch on today are healthcare policy trends at the gubernatorial level. Investment in behavioral health has also been high on the agenda for many of our nation's governors in 2021. At least 9 governors mentioned significant investments in their state's behavioral health care infrastructures and services during their State of the State speeches this year. For example, Arizona Governor Doug Ducey spoke about the impact of the pandemic on opioid abuse, alcoholism, addiction, mental health issues, and quote, the sheer loneliness of isolation, as well as suicide. Missouri Governor Michael Parson talked about plans to invest in community mental health and substance use disorder advocates, as well as crisis stabilization centers in his state. And then Tennessee Governor Bill Lee mentioned the inclusion of $6.5 million in his budget to provide services for school-aged children struggling with mental health issues. Efforts to expand health coverage and access to care were on the minds of many governors as well. A number of them highlighted the critical role that telehealth played during the pandemic in maintaining access to health services. And of course, that's a topic that Sean has already touched on. Governors also highlighted efforts to lower health costs of consumers affected by the economic impact of the pandemic. New York Governor Andrew Cuomo proposed the elimination of healthcare premiums for some low-income New Yorkers. Similarly, New Jersey Governor Phil Murphy pointed to the success of the state's state-based marketplace in lowering premiums for some. Finally, a number of governors announced the commitment of funding to address healthcare provider shortages and to provide associate degree programs in the healthcare field. Nebraska Governor Pete Ricketts mentioned plans to expand the workforce by making pandemic-era flexibilities permanent that allow out-of-state providers to practice in Nebraska. Next slide. And with that, Sean and I would like to thank you for your attention this afternoon. We hope this presentation has revealed some of the areas of interest that are ripe for exploration by this task force in the months ahead. And I will turn it back to Sean to see whether there's time for questions now or if we're going to go right into break. But again, thank you all for listening, and we look forward to hearing about your work as you move forward on this effort.